All right, I'll go ahead and start. For those of you on the call, I'm Ryan. I'm one of the fellows of the San Diego Spine Foundation. I'm neurosurgery trained and don't have any disclosure for this talk. Just want to say that I'm going to be talking about kind of a comprehensive review of how to treat spinal metastases. While I don't have any disclosures, my opinions and my experience are very much shaped by spending a year at Memorial Sloan Kettering, largely under Dr. Bilski. So those are my caveats to this talk. So first wanted to kind of just present a case that was seen in scripts here when Dr. Mundis was on call a few weeks ago, and kind of wanted to see, put this talk into larger framework. But just wanted to see and hopefully this talk give you the tools to deal with this if this comes into your clinic or your or the hospital while you're on call. But this is a 51-year-old female who comes in with 3 to 4 months of back pain, so questionable urinary incontinence that made her resolved. On the MRI scan, shows kind of some vertebral body involvement of tumor, but extending into the nerve roots into the cauda equina. And the question, what the oncologist and primary team was having for us was, what do we do next? So I'll go through the framework of what to do with this kind of patient shows up in your clinic and what the appropriate next steps are. So first one to start, spinal mets are the most common tumors of the spine. In 20% of patients with cancer, some sort of spread comes to the spine, whether it's the epidural space or the osseous mets to the vertebral bodies, but it is a really high rate of all patients. Up to 300,000 adults are newly diagnosed in the U.S. every year with spinal bone metastases, and for a variety of reasons, thoracic is the most common, followed by lumbar, followed by cervical. Most of these patients that spread to the spine are from a breast primary, followed by lung, followed by prostate, and then the renal, GI, and thyroid kind of rounded out. And a lot of the kind of collection for the primaries to spread to the spine are usually due to presence of rank and NF kappa beta. There are several different ways that the mets spread to the spine, but the most common is through the hematogenous pathway through back plexus system, which is a series of vellus veins that are usually due to deep lymphatics or deep tissues of the body, including the renal cells, the kidneys, the retroperitoneum. So that usually is the number one way that the cancer spreads from the primary site to the spine. Sometimes it's tract tumors extension. If the tumor is in by proximity, it can spread straight into the epidural space or into the osseous space, and then through the lymphatics is the third most common way that it spreads. Most of the patients present initially with neck or back pain, 83 to 95% of patients. It's an aching and deep pain. It wakes patients from sleep. And another common way is when the tumor causes mechanical instability, which presents as mechanical or axial load pain. The reason that it usually presents when the patient wakes the patient from sleep is a lot of times the pain is kind of abated by the cortisol levels. So when your cortisol is as low as, which is usually in the middle of the night when you're sleeping, it usually all that pain kind of starts up, and that's when that pain gets worse, and that's why it wakes you up from the middle of your sleep. Symptoms really depend on the location of the tumor. If there's an epidural extension and if there's cord compression or nerve compression, that's going to cause a different kind of symptoms than if it's just in the bone, causing a pathological fracture. And in general, the more severe the deficit, the worse the recovery after either radiation, surgery, or observation. An important thing to realize for treatment of metastatic disease of the spine is that it's always purely palliative. You're never going to be able to get any sort of cure without systemic, in some cases, systemic disease or systemic therapy can do that, but surgery is never going to be a way to cure disease. So every time you're seeing one of these patients, you have to understand that any kind of treatment you're offering is always pretty much purely palliative. So the goals of surgery or any treatment are to restore neurologic function if they have a deficit, alleviate pain, which a lot of times that's their primary complaint. And for a lot of these patients that are really sick and have a limited prognosis, that's kind of what you're really aiming for. Achieve spinal stability, which can help with the pain, and then the last thing is to prevent local recurrence. And these patients oftentimes have very poor prognosis is you want to just increase their quality of life for the remaining time of life that they do have. So what do we do? So that 51-year-old comes into your clinic with 3 months of back pain. What do you want to do, and how do you want to work up this new diagnosis? No known primary, no other really past medical history. It's easy to start with MRI of the neural axis versus a CT myelogram. MRIs are preferred. Usually the preferred sequence I like to look at before anything else is a T1 without contrast. I think it gives you some sensitive exam. Type of exam and can really give you a clue on where tumor is most involved with the vertebral bodies. Certain times, if you think that there's a lytic lesion or you need more information working up for surgery, you want to get CT of the affected area. In terms of systemic workup, you want to see if it's a primary, especially if this is a patient with a no known cancer diagnosis. You have a couple of different options depending on the institution and how readily available it is. CT cap is usually the easiest and most readily available. However, a PET scan or a T699 bone stratigraphy scan is also available. Usually those are more available in an outpatient setting, but those are good ways to see if there's other systemic areas of the tumor. And then you can do tumor markers as well, depending on what type of primary you think you have, whether it's prostate for PSA, and then some of the other ones, multiple myeloma, FPEP, UPEP, IgGs for some other types of cancer. And for a patient, a stable patient with no neurologic compromise, a core needle biopsy is preferred over a fine needle aspiration. And if you have time, you always want to try to get a new diagnosis. Sometimes if there's concern for chordoma, you can do things like dye the tract, so that if it does come back as a primary cancer, you can try to take the tract out on the way out. But the caveat is, if there is acute neurological compromise, you don't have time to wait for this new diagnosis and work the patient up. So you got to proceed to urgent decompression, which can be hard because sometimes we talk about these patients wouldn't require surgery and might be a better candidate for chemotherapy or radiation. But in these acute neurologic compromise, when you don't know, even if you have a suggestion, you kind of have to proceed to urgent decompression. I just kind of want to go over a quick history of how spinal metastases have been treated and kind of walk you through where we are now today. In the 1970s and 80s, the kind of options were laminectomy without instrumentation versus continuous or CBRT. Laminectomies had their own pitfalls, a lot of iatrogenic instabilities, as we've seen in the degen and deformity world, causing deformity, progressive pain, neurologic decline. And radiation had some response rate for some of the more radiation-sensitive cancers we'll talk about. But in general, radiation was just as effective as decompressive laminectomies in treating epidural spinal cord compression. And that was kind of the consensus for a while, as the Posner group out of Cornell Sloan published in the 1978. From 1990 to 2010, instrumentation really made advances, went from hook and rod system to where we are today with screw rod system, lateral mass particle screws. Embolization for bloody tumors came out in 1990, so another tool to treat those. I'll talk about the patchel study in a second, but that was really the thing that really changed in popularized surgery for these metastatic diseases. During this day, I think Dr. Kaslan, who was previously at MD Anderson Baylor, he really developed this field, and en-bloc spondylectomies became very popular, both for primary tumors as well as oligometastatic tumors like renal cell. And things like surgery-based algorithms came out as well. Like I mentioned, the Roy Patchell study, 2005, really was kind of the thing that really changed the field, and was a randomized trial where they looked at direct compressive surgical resections in the treatment of spinal cord compression. And what they found was patients who underwent surgery followed by radiation, as opposed to patients who just had surgery or just had radiation. Patients who underwent surgery had a lot more time ambulating and really improved the quality of life. So this is kind of what changed it and popularized in surgery for these patients. Where we are now is, for at least for metastatic disease, is more of a multimodality regimen where we're doing surgery followed by radiation or just radiation. The real advance is SRS or stereotactic radiosurgery or hybrid therapy, where you do separation surgery plus SRS. There's been a lot of committees working with AO tumor group looking at what the mechanical stability is and defining it so everybody's on the same page. The popularization of kyphoplasty or vertebroplasty to treat some of these standalone fractures that might be stable but are causing a lot of pain. And then things like the NOMS framework developed by Dr. Bilski's group at MSK kind of made it kind of easy for providers across the country and world to make these decisions. So let's talk about radiation for a second. There's two main types of radiation. There's for external beam radiation therapy, not talking about excluding things like brachytherapy. But the whole premise of radiation is that you're preferentially damaging malignant cells while avoiding damage to normal cells. The malignant cells are the ones that are replicating at a much higher rate. So you're radiating them, you're damaging those malignant cells. And there's a bunch of different types of tumor volumes that you're planning. There's gross tumor volume, which is the tumor volume that you can see on the MRI scan or a CT scan, which is the large area that you're trying to kill with the radiation. The clinical tumor volume, which is the microscopic disease, a little bit around there, and the planning tumor volume is the areas you're targeting with the radiation. And the main things you're kind of keeping in mind is the organ at risk, because when you're radiating, especially depending on the type of radiation, putting other organs at risk, including things like the bowel or the pharynx, esophagus, things like that. So you have to be mindful of that when you're working with a radiation oncologist to plan the radiation. And there's two different types of radiation that are most popular: conventional external beam radiation, which is kind of the traditional radiation that I mentioned in the first slide in the 1970s and 80s, and then SABR, which is a higher dose of radiation per fraction with less fractions. And this is really what's been the game changer and allowed separation surgery to kind of come as effective as it is today. This is a conventional field. We still use it largely for more classically radiosensitive tumors. As you can see on this axial cut of the CT on the left, it has a lot more wide dose of radiation given. So usually these are given 30 gray over 10 fractions, so 3 gray per fraction over a much larger dose. SPRT, as you compare to the last slide, is a lot more targeted. You can target specific parts of the vertebral body, epidural space with a lot more efficacy than you would with the conventional radiation. And like I mentioned, the main benefits of stereotactic radiosurgery are you're able to give a high dose per fraction in a much more conformal field. Doing 3 gray per 10 fractions as opposed to in CBRT versus you're doing about 8 gray in 3 fractions or 5 fractions, depending on what you're treating. So short treatment. And then there's the abscopal effect, which means that if you radiate one area, they found out that actually treats systemic disease as well. Even though you're radiating the lumbar spine, your tumors in the cervical spine is an immune response, which causes some shrinkage of tumors in other areas of the body. A quick a review of this, just showing that without causing cord compression. Grade 2 is cord compression, but you can still see CSF around it. And grade 3 is cord compression with no CSF surrounding the cord. The next part is oncology. This really depends on what the primary is, and there's a ton of different buckets of how radiosensitive these tumors are based on conventional therapy. So like I said, SRS has kind of changed the game, but the classically sensitive ones are where you want to go start with radiation first, are lymphomas, germ cell tumors, myelomas. Intermediate is breast, prostate, ovarian, and non-small cell lung cancer. And then classically resistant are things like sarcoma, melanoma, colon cancer, renal cell, thyroid, and hepatocellular. And like I said, this was based all on radio sensitivity, CBRT, 30 grain time fraction. And with this conventional group, their median response duration took for at least 11 months and a 2-year local control rate of 86%, as opposed to these radio-resistant groups where the response duration was only 3 months and had a 30% 2-year local control rate. The next thing, and I don't want to belabor today, but the SINS is kind of developed in that 2010 period of time. But this is a way to classify tumors when they invade the body, if they cause instability or not. Just like things for cervical spine fractures or TLR scores, most of these patients inevitably end up in the indeterminate group, 7 to 12. But this gives you a rough guideline of if the fracture is stable versus unstable. Having talked to some of the surgeons who are on this initial group that came up with SINS, the thing that they wish that they had made a bigger emphasis on in the SINS score, if they had to do it again today, is pain. Right now, pain is 3 points for pain, 1 for occasional pain, 0 for pain-free lesion. But a lot of times, what's guiding you to decide if the patient has mechanical stability or not is if they're bearing weight, if they have pain. If they do have pain, a lot of times you're going to want to take these patients to surgery to fixate, just to stabilize, because a lot of times these fractures can cause a lot of pain. Then the S in NOMS is systemic therapy. A lot of times this gives you prognostication. If the patient has low platelets from systemic cancer invading their bones where platelets are produced, the liver, they're not going to be as good of a candidate. If you have a limited amount of time left prognosis, it's somebody that you're not going to want to take to surgery. Somebody that might die on the table or might not have that long-term quality of life benefit that you're going to glean from taking these patients to surgery. And there's been a lot of development in postoperative chemotherapy, immunotherapy in the last 15, 20 years. Things like immunotherapy, immune checkpoint inhibitors, anti-VEGF, and alkylating agents that are now having patients that have classically terminal illnesses. Now you can see them with no evidence of disease and living a pretty normal life once they're sometimes cured from these systemic therapies. And there's a lot of new targeted therapy data. So we want to look at these, and things like non-small cell lung cancer. A recent systematic review found that patients with EGFR inhibitors are living a much better life. So if these patients can get on these more targeted therapies, they can live longer, and we can think, and that can guide if we're taking the surgery and what surgery we are doing for them. A good way to classify prognosis, there's a couple different ones. Classically, the Tomita and Takahashi score system was the best way to give kind of a overall oncologic prognosis. There's the New England Spinal Metastases score, and there's the SOAR group. But if the patient is going to live less than 3 months, in general, you're not going to want to take them to surgery. This is an example of SOAR. Has a bunch of different labs as well as clinical factors that you put into to their calculator. This patient put everything into it, give them a 18% survival rate at 90 days. So that can guide whether you're going to offer surgery or not. In general, if patients are able to ambulate before surgery, just like other ways of when patients present with different kind of neurological deficits, if they've been able to walk before, they're more likely going to be able to walk after. So you want to get to these patients before they're too heavily impaired by their tumor burden. Steroids are always a big question. Do you want to give steroids? Just like in trauma literature. However, based on the systematic review out of 2017, there is evidence to support giving a 10 milligram bolus followed by usually Q6 as opposed to sometimes giving 100 milligram bolus followed by 16 Q6. In terms of surgery, a lot of different options. There's the en bloc, which were popularized more in the 90s to 2010. Um, there's preoperative embolization as a therapeutic option, SRS surgery, ablative techniques largely for patients who can't undergo surgery because of their medical condition, and then kyphoplasty. But more and more, there's a trend towards minimally invasive surgery. En bloc spondylectomies at this point are usually reserved for primary tumors, not really much in the metastatic disease, but it used to be a much more popular option for SRS. Things sometimes when you take out the anterior column, you'll want to put in a cage, just like we do during a PCR for deformity. But like I said, separation surgery is kind of the mainstay of treatment for these pathologies. The full premise of separation surgery is to separate the tumor from the cord so that when you are radiating with SBRT after surgery, there's that 2 to 3 millimeter gap so that you're not making the cord at risk and you're not radiating the cord. So why separation surgery versus a classic en bloc or a vertebrectomy? The shorter operating times, 2.5 hours, 3 hours usually for these cases, versus much longer for these en bloc or these vertebrectomy cases. And oftentimes these patients have a limited prognosis and are very sick with their primary tumor. So shorter time, the better the outcomes. They're more replicable. You can do them in the middle of the night without having a lot of hardware, calling in your rep. All you need are screws and a rod. And there's no need for a approach surgeon. You can do it, the neurosurgeon, orthopedic surgeon can do it by themselves, decrease morbidity, and it's usually safer. This is Dr. Bilski and Lockford's data out of MSK in 2013. They looked at 186 patients from between 2002 and 2011. A lot of these patients were classically radioresistant. Looking at different SR strategies, whether it's just single fractionated 24 grade times 1, hyperfractionated 8 to 10 grade times 3, or low dose hyperfractionated. They found with their data that there was only a 16% cumulative incidence of recurrence, and with a high dose hyperfractionated, this was a 4.1% incidence of recurrence, which is very similar to doing a more extensive morbid operation. And there was no neurologic complications in their cohort, and there was no association or with recurrence with the classically radioresistant or patients that had previous radiation or epidural extension. There is a role for preoperative embolization. There's a list of tumors that you probably want to embolize prior to taking the surgery to minimize blood loss. But renal cell is kind of one that really stands out. There's thyroid, there's hemangioma, things like that. I mentioned it earlier before, but this is the kind of the international radiation guidelines for how they plan SBRT. But what you want to do is you want to treat clinical target volume, not just the volume you can see on the MRI that contrast enhances or that is hypo intense on T1, but you want to be able to account for microscopic spread as well. What kind of implants do you want to use in these cases? Say you're taking the patient for some sort of decompressive surgery and stabilization. All depends on your goals of surgery. There's most common are PEEK, titanium, and carbon fiber. At this point, it's usually between titanium and carbon fiber. But the thing to know is that really, as opposed to deformity, where we're using 5.5, 6.0, 6.25 cobalt, really no role for cobalt rods, just because of the artifact limiting both your postoperative SRS as well as if there's progression. And I'll talk about carbon fiber in a second, but sometimes you'll use carbon fiber screws, but because you cannot bend carbon fiber rods, you can use a combination of titanium rods with carbon fiber to get a lot of the benefits of carbon fiber. This is a image I pulled from one of my colleagues at Ohio State, using a combination of carbon fiber screws with SI bone granite pelvic fixation to treat an S1 fracture. As you can see on the axial cut of the CT scan, there is much less artifacts, or there's really no scatter beam on the CT scan, much less on the MRI for when you're planning radiation afterwards. So in my experience, most of the time you're using carbon fiber, not necessarily for metastatic disease, unless the radiation oncologists are wanting to use proton beam therapy, which the artifact from titanium can obscure it. So they're doing a redo radiation case, your radiation oncologist might ask you to put these in to improve their planning as well as to improve uh, observation of the tumor at a local site with serial MRIs. There are options for ablative techniques, radiofrequency ablation, cryoablation, lit. I won't belabor these, but these are usually reserved for patients that cannot undergo a surgery and need to have surgery under local sedation or MAC. And radiofrequency ablation uses a high frequency current to cause thermal necrosis and locally kill the tumor. Cryoablation cools the tumor and usually preferred for osteoblastic tumors. And then lit, which has really been popularized in the cranial space, largely for epilepsy and for deep-seated metastatic disease, but is called short for laser interstitial thermal therapy, and has really been popularized by the MD Anderson group. But basically involves putting a probe under visualization under MRI and then burning the tumor under that. Kyphoplasty is really important treatment for pathological fractures for patients who have pathological fractures of the vertebral bodies. And in the CAFE study, this is kind of the main evidence for performing these vertebroplasties, kyphoplasties, but a significant reduction in pain and improvement in disability indexes at up to 6 months with kyphoplasties. For surgery, most of the separation surgery I did last year, we would do one level above the fracture and one level below the fracture. And what really classically is always 2 levels above and 2 levels below, but what really changed it is the ability to cement augment. So for almost all these cases, if you go 1 level above and 1 level below and you cement augment, the patients have a very low risk of hardware failure. Then there's post-operative radiation. When do we want to give it? You can start SRS a lot sooner than you can conventional radiation, just because you're sparing the skin with SRS. So usually about 1 or 2 weeks after you're done with surgery, you can start SRS versus conventional want to give 2, 3, 4 weeks to minimize risk of wound complications, which are happening at a lot higher rate with these patients under systemic therapy who already have impaired wound healing. This is an example of pre-op versus post-op separation surgery. You can see the MRI with looks like an ESCC3 cord compression afterwards, separation surgery. While you can see on the sagittal plane of the CT, there's still tumor in the body. The myelogram shows that there's no cord compression, so now you can safely radiate with minimal risk to the cord. Something I never really considered until I started doing a lot of these surgeries are we actually fusing these patients or are we just fixating them? There's been only one article I could find in recent years published out of the Hopkins group looking at what are the fusion rates after these kinds of surgeries. This particular article is limited by being both in primary as well as metastatic disease, but you're looking at a 36 to 100% fusion rate. For metastatic disease, you're closer to a 36% fusion rate, but a lot of times, just because there's an on-label warning for oncologic disease, you can't use BMP in these metastatic diseases. So you're usually kind of confined to local bone graft or autograft iliac crest. Occasionally, if the patient has a really good prognosis, you could use a vascularized rib or fibula graft, but usually it takes about 6 to 12 months to fuse, and a lot of times these patients aren't living that long. So the goal of surgery is actually more to fixate, and at least, and I'll talk about it later, sometimes you'll go into fixation and patients end up living a lot longer than you think so. So you think they initially will, so then you'll go back and then redo and add more hardware and then actually try to fuse. In general, though, the trend for these metastatic spine diseases going from minimally access and minimally invasive surgery to working on quality of life, improving how you're making the constructs, and targeting final therapies with these systemic and immunotherapies. I want to talk about a case from when I was a chief resident Rush. This was a 74-year-old male who came in with weak back pain, 3 days subjective bilateral extremity weakness, no known oncologic history, with 5 out of 5 strength with hyperreflexia. And I just kind of want to go through the NOMS framework for this. This patient, although he still 5 out of 5 strength, on the MRI scan, this is a T1 with contrast, but on the T2, there was no CSF seen, so he's grade 3 ESSD myelopathy. So because of that, we can't do what we would do if we had more time, which is take a corneal biopsy, wait for a diagnosis, and then make our treatment plan. But in this case, even though he's stable neurologically, he's already presented with bilateral lower extremity subjective weakness. So kind of are forced into operating just purely on this MRI finding. Is the oncologic, what is it, radiosensitive, radio-resistant? CT cap showed what looked like to be a renal mass, so we have presumed renal cell carcinoma, which is classically radio-resistant. Mechanical, we put him into that SINS framework. He's a SINS score of 5, so he's less than 7, so he's stable. Systemic, we put him into sorghum milligram, has a 90%, 90-day survival risk. Based on this, renal cell, which is classically a very bloody tumor, we sent him for a pre-op embolization. It ended up in this case because his whole body, vertebral body, was filled with cancer. When we did separation surgery, which was the goal, we actually ended up destabilizing his anterior column, so ended up being a Cajun, but just went 2 levels above and 2 levels below. After spending some time here, I've been doing a lot of thinking and seeing, is there a role for any alignment parameters in these cases? Obviously, in deformity, that's become very important, and a lot of times, if you can align them properly, their revision rate goes a lot lower. In the metastatic population, there really hasn't been much research done. There's been, out of Rory Goodwin's group out of Duke, there's been one review looking at alignment and alignment parameters in primary and metastatic disease. And what they came up with is it's important, but we really haven't studied enough to make any sort of conclusions. Over the last 20 years, there's been just so much more improved survival. Lawford at MSK published this study showing this improved survival rate. So classically, the goal for these patients, like the SILS, is palliation. Want to improve their symptoms, want to improve their quality of life for the remaining part of life. But what happens when these patients are cured from their, or they're cured from their metastatic disease? We might have to start thinking about different types of treatment and maybe a more robust construct. Separation surgery, out of 2013, they looked at, a group looked at 318 patients, and they found, largely probably because limited by the overall length of survival, but they only had a 3% failure rate. And most of these were raw screw breaks, screw pullout, or symptomatic vertebral body fracture. And what they found was risk factors were junctional spine, it was TRL or cervical thoracic, or postmenopausal females. But as you can see here, looking to the left, this was, I believe, a colon cancer that spread to the spine. Is involved in the pedicles as well as the anterior column. They fixated alignment, looked okay at like 90 days post-op, but the tumor progressed, caused symptomatic fracture, and the patient kyphosed over. So what do we do in these situations? Another example of deformity created in spinal, patient with spinal metastasis. This patient, I believe, had a HPV-associated squamous cell of the oropharynx. Ended up getting radiation, developed torticollis and fibrosis from the muscles from the radiation. Didn't improve with paraspinal Botox, so ended up doing a O to C4 fusion with a patient already in a PEG, already with a PEG tube, to improve his chin on chest deformity. Another case that I wanted to talk about is a 57-year-old female who ended up having you can't really see it here, but on the L4 body had spread to the L4 body from her metastatic leiomyosarcoma. Based on the CAFE study, did a solo standalone L4 kyphoplasty. Tumor progressed, ended up having some epidural compression, so taking a separation surgery, L3 to 5 fusion. API lateral looked good, stabilized across that fracture segment. However, I think about a year out, patient was doing well from a systemic standpoint, ended up fracturing both of her screws at L3, and you can see in the apian lateral plane. So decision was taken back, extend a level above or level below. But based on cases like this, we looked at 445 patients that underwent 1 or 2 level kyphoplasties. And the question is, when should we take these patients to fixate them first versus just doing a kyphoplasty? So looking at these almost 500 patients with an average age of 65 years of age and a preoperative score of 9.1, we look to see if we could predict when these patients should be fixated first with a percutaneous augmented procedure, one above, one below, versus just going to kyphoplasty. And what we found is that patients already with a high segmental kyphosis, usually compromised, usually associated with a high vertebral body height loss, or patients with a higher sin score, or on the kyphoplasty, if there was a higher pressure needed, maybe we should fixate these patients first. One final thing I wanted to go talk about is socioeconomic factors as well when taking care of these patients. As we know, medicine is expensive, cancer care is really expensive, and what was striking to us at Sloan when I was there was that 42% of patients who were newly diagnosed had all their life savings depleted within 2 years of treatment. So it's really important to be cognizant when treating patients that you can easily bankrupt them, and there's this can sometimes be their primary concern, not necessarily just being cured of their cancer. So what we looked at is financial toxicity, which is the objective and subjective financial burden experienced by patients as a result of cancer treatments. And there's been a lot of studies, not necessarily in the neurosurgery or spine literature, but in the breast cancer space or lung cancer space, that it actually will affect their quality of life and survival if they do have a higher rate of financial toxicity. Examples of the severe issues that can lead from financial toxicity, high risk of costs in the lung cancer population, chemotherapy being one of the highest drivers of these increased costs, but surgery is close second at 24%. And the way we sought to define this was three different ways. If the patient had payment issues, if they needed financial assistance, or if they needed the help of social work. We looked at all our patients that I think close to 900 patients that had undergone some sort of spine surgery with metastatic disease, and prior to undergoing surgery had a 17% risk of financial or 17% incurrence of financial toxicity, whereas just patients without a fusion had, but undergoing some sort of decompression, had a 15% risk. What was striking to us is that after they had some sort of surgery, their rates jumped to close to 40% financial toxicity rate. So that's kind of another area that we're looking at, and we're looking at ways to mitigate that and decrease this rate of financial toxicity. In conclusion, wanted the 70s and 80s, when this field first came about, radiation surgery and systemic therapy were all different options and not really used in conjunction. Where we are today is there's an overlap, but I think where we're going to see the field go and next steps are where there's going to be much more of an overlap. And it's important because of this to talk to your colleagues in different areas and work closely with them when you're treating these patients. That's my talk, so I'm open for any sort of questions.
That was awesome. Thanks, Ryan. The financial toxicity piece is like pretty crazy, huh? Like,
yeah,
the fact that we're hurting people. I mean, we're not hurting them. It's not. It's just like the financial burden of this is incredible. So, I don't know how to get around that. I don't know if there is a fix for that, but
there you go. Yeah, not in our space, but at Sloan, one of the oncologists is really working hard at this, and they're looking at designing like prophylactic interventions to work around it. And there's actually shown it's improved the quality of overall length of survival from this. So I think there's definitely a role for it.
Yeah.
Yeah, good talk, Ryan. A lot's changed in, gosh, the past like 15 years and how these are approached. I think the NOMS criteria has been really helpful in determining what treatment strategies to employ. And I valued what you said about sort of rethinking sort of the sin score and maybe hedging pain a little bit higher, because that's really a truthful statement with a lot of these cases. And then I also appreciate that you touched on the deformity aspect. And I think those of us that have been practicing for a while see a lot of these patients live quite a while. They kind of outlive that, 1 to 2 year range that, we traditionally would think of. So I think putting people into a good alignment parameters is really should be one of our goals when we're doing these things, particularly, if you're doing something more than just a separation surgery to preserve function, because if they're kyphotic or something like that, that really should be taken into your strategy, because many of these patients do live, particularly with things like breast and prostate. Some of these people live 20 years.
Yeah, there you go.
No, I definitely agree, and I think that's something that I want to look more at as I start my career.
Ryan, that was a great talk. Just clarifying question. There's still no difference in terms of the lifetime maximum radiation dose between the two, right?
It's actually it's not about lifetime radiation dose, at least from what I know. It's more about organ at risk. So you can radiate, say you're radiating lumbar spine, you're worried about the colon. You can radiate, and after about I think about a year, it kind of resets. So you got to really work closely with your radiation oncologist, but it's more about the organ at risk rather than it is just like lifetime risk.
Okay, yeah, that makes sense. Thanks.
All right, awesome. Thanks, Ryan. Be respectful of everyone else's time, but any other questions before we end up for everyone off to their week? But great job, and I certainly look forward to seeing what we're gonna be doing over the next 15 years, because I'm sure it's gonna change again.
Well done, Ryan. Thanks for doing it.
Thanks, everybody.
Have a great week.